Hi, my name is Josh Brody. I run the lymphoma immunotherapy program at the Icahn School of Medicine at Mount Sinai in New York, in America. Very exciting to be here at the 2025 ASH annual meeting. A lot of awesome updates and new things we hadn't heard about before, things that could be really helpful to our patients in the near term, sometimes things that are more effective than the old therapies and safer than the old therapies. A lot of win-win. So one example of that, hopefully, is we are presenting an update of a trial we've already described before, combining a standard of care chemotherapy for relapse refractory diffuse large B-cell lymphoma, GemOx. This is a standard of care, and we now have a few trials of GemOx versus other things, but our particular approach is to add an immunotherapy to this standard chemotherapy. That immunotherapy is a bispecific antibody, a CD20 by CD3 bispecific antibody. Grab the lymphoma cells, grab the T cells, activate the T cells, kill the lymphoma cells. This is called Epcoritamab. Epcoritamab already is standard third-line therapy for DLBCL, but we're trying to see if we can make it more effective by combining it with standard chemotherapy. And the background of this is that GemOx is a standard of care, but not a great one because the complete remission rates with GemOx nowadays are like 25%. 3 out of 4 patients are not getting the results that we need, so it seemed like a no-brainer to add immunotherapy on top of that. The punchline is that with Epcoritamab plus GemOx, we saw a huge increase in the complete remission rate from that historical result of 25% up to a 60% complete remission rate. Most patients were getting a complete remission, so that's already been a bit described. And the safety was pretty good. The GemOx is not benign. It has some side effects, some neuropathy, some cytopenias, some infections. To be fair, we did this trial kind of pretty deep in the COVID pandemic, so we saw a lot of infections. We saw infections in our patients that were not getting therapies as well. So the safety was pretty comparable to GemOx by adding the Epcoritamab on top. And again, the efficacy hugely improved. Now we see with more than 2 years average follow-up, a lot of these patients are still in complete remission, a majority of them. So just contextually, we used to just say frontline aggressive lymphoma is curable 60% of the time. Second-line DLBCL may be curable with auto-transplant, maybe less than a third of the time. May be curable with CAR-T, maybe 35-40% of the time. And historically, we generally said later lines of DLBCL mostly incurable. But that's a stupid thing to say because the disease is never incurable. It's on us. The disease is potentially curable. We need to find the cure. That's on us. So I do not want to say that, bispecifics plus chemo are curing these people, but with more and more follow-up, it's starting to look more and more likely that we are curing a significant proportion of these patients. Again, I can't quite give a guarantee because I see these patients still in follow-up every month or two, and they say, wait, am I cured or am I not? And we say, you're on the path to cure. You've been in complete remission for years. That is the only way we can start to define a cure. Unfortunately, we don't have a perfect test. Complete remission is a good test. It's not perfect. Durable complete remission, that's the test of cure, and we are getting there for a lot of these patients. So very gratifying to be able to share this update with the larger community here at ASH, and we're very optimistic that this is a significant, impactful thing for patients right away today.
If our videos have helped you in any way, and you're able to, please consider making a donation to help us continue this important work.
Your gift will go 3 times as far when we reach $500,000 by the end of the year.
Every contribution, big or small, makes a difference, and we're deeply grateful for your support.